So, we are going to go ahead and talk about sleep wake disorders. The best cure for insomnia is getting a lot of sleep. So, once again, we want to look at DSM criteria for sleep disorders related to behavioral mental health diagnosis, as well as our ICD 10. It has evolved over the years, sleep disorders, how we diagnose it, and how we approach it. What I want you to do is take a step back when working with a client. When they complain about sleep, many times we don't really take it serious. We're too busy looking at their depressive symptomology, their anxiety, their life. We're trying to collect a good history to make some diagnosis, but we don't really get deep into their sleep. And then sometimes we just blame it on a medical issue, or we'll blame it on their obesity, or we'll blame it on their current situation, why they're seeing us. We need to at least look at some key factors, and that is, do they have difficulty initiating sleep? Do you have difficulty falling asleep? And many times I will then go ahead and ask the client, do you have racing thoughts? Are you so busy trying to get everything done? Are you thinking about tomorrow? Do you have negative thoughts when you're laying there at night in bed? Then there's difficulty maintaining sleep. Do they wake up? And when they wake up, what are they thinking about? What's going through their brain? What are they doing? We always want to look at behaviors related to these things. Can they fall back to sleep? And then, of course, early morning awakening. Good sleep hygiene and trying to get a good sleep history is very, very important. So, of course, then we get into the causes. Clinical impairments. We want to look at time frames. How many times per week does this occur? How many times per month? Is this every day? How many times a night? Are we tired or fatigued or have difficulty waking up or difficulty falling asleep, or we wake up early regardless of how much sleep we get? We want to make sure that they don't have a diagnosed sleep disorder and they've never had a diagnosed sleep disorder. Oh, yes, I have that machine. It sits there, or I boxed it up, or I got rid of it because it got moldy, or I didn't use it. Any medications that they use, any new medicines, or are they using some sort of substance that you're not well aware of? I also like to raise the point of, I'll have clients, I start talking to them about their sleep, and I say, well, did you start drinking any new teas, taking any new herbal supplements? Did a friend give you a vitamin, or did you start taking any new vitamins? I've had clients, oh, yes, I was at the store, or I was at a health food store, and they gave me a new herbal tea, and they said that would help me relax. And then, of course, anxiety, depression, or any other psychiatric diagnosis. So we're looking at sleep onset, sleep maintenance, non-restorative sleep as our main key factors. How is it impairing their world? You always hear me talk about impairment. People can complain about a lot of things, but what I always want to know is how it is impacting your life. When we discuss symptomology, we also want to know, do they have lots of energy at night, or are they really tired at night? I also many times will ask a client, are you tired during the day? How do you feel during the day? I don't care if you're not sleeping at night, if you're okay during the day and you're functioning and you have no impairment. Sometimes I need to re-educate. It's not, I get parents will tell me their kids have a problem, and then I start going, well, what time do you put them to bed? Well, 8 o'clock. Well, they're 12 years old, and you're putting them to bed at 8 o'clock, and, 7 or 8 o'clock, 12 hours, that might be too much for them at this age. or 7 o'clock, they're trying to put them to bed. I get elderly, and I get different clients that will tell me that they go to bed at 8 or 9 o'clock or 7 o'clock. And then they want to know why they're waking up at 3 or 4 in the morning. Well, you only need so much sleep. The body only needs 7 to 8 to 9 hours of sleep. We all have, as I always say, magic number. Now we can hit the literature and we know we need 7 to 8 or 7 to 9 hours of sleep. Teenagers and kids should get more. But how do we feel is what we always need to be talking about. Risk and prognostic factors. So is it temporary? Is it something new? So I often will say to people, are you having any financial stressors, job or work issues that have come about, a new boss? Are you having some friendship issues? Are you having kid issues and family issues? School issues, right? Is there a variable out there that we can fix? Did you move recently? Did you change your room around? Noise, light, temperature, and then genetic and age. So we often will go ahead and get sleep studies, and we're going to now talk about a lot of those factors. I highly recommend that you go back in your pathophysiology book and look up sleep and the different stages of sleep, REM sleep, non-REM sleep, and how it's kind of defined. Stages of sleep we still often will utilize, but more often than not, you'll see REM sleep and non-REM sleep. But regardless, it's all about physiological factors, okay? And looking at that. So are they getting adequate amount of sleep in each of the sleep cycles that they need to achieve? Then, of course, it's chemistry of the body, or maybe some sort of medical condition we don't even know about. So many times there are factors that we don't even know about. Most people will tell you restless legs, or a spouse or somebody else will tell you, oh, they move so much when they're sleeping. Maybe some chronic pain, COPD, substance abuse. Maybe they stopped taking a medicine a week or two ago, or they cut down on how much they were drinking at night. So how do we define a diagnosis? Well, of course, we can have people recall their sleep and keep a sleep log and journal about their sleep. And that might help us. Most clients that I have will complain about the fatigue and tiredness and that they can't sleep at night. And that's how I start my approach with getting a good history. How many times per week, how many times per month, as we mentioned before? How distressed and how impaired do they appear to be related to sleep? Is it impacting work, family? Family telling them that they're cranky, irritable, depressed? Can it be explained by some sort of other disorder? How long has this been going on? And of course, in the DSM, we're always looking to see time factors and how often, how long and how often, so we can put some sort of modifier on it, mild, moderate, or severe. Narcolepsy has come to the forefront. Some narcolepsy meds have hit the market over the past decade. A lot of people that do shift work, we call it shift work disorder, sleep disorder. But these are people that truly are falling asleep regardless of how much sleep they get during the night, throughout the day. So review over the next couple of slides. You will see, I will move rather rapidly. You need to do the different DSM criteria for diagnosing and understanding the pathophysiology, such as narcolepsy with the REM and REM sleep and how it works and why it's diagnostic. A key factor with narcolepsy is that typically the symptomology appears before or in childhood, before adulthood. You really get a good history. That's why history is everything. Your textbook also does a really good job explaining the pathophysiology behind many of these sleep disorders, as well as risk factors for each of them as we go through it. So who diagnoses sleep disorders? Well, normally a pulmonologist. Pulmonologists are normally trained and certified in sleep disorder medicine. And we're going to get a little more into the whole sleep apnea or the obstructive sleep. And that's the most common. Many times clients say, yeah, I was diagnosed, or yeah, I do have that machine, or they won't even disclose it to you because they know that's the cause and they just want the magic pill because the machine is annoying. And as I tell them, that technology changes, and the machine that you wore 10 years ago is very different than the machine of today. And they must remember that. Obstructive sleep apnea. Obesity is a big factor in it, but you might want to also send them to an ear, nose, and throat specialist because there might be something physiologically that can be done as well for them. Comorbid obstructive sleep. So you have your cardiovascular and some other comorbid conditions that can cause it. Sleep centers were the thing that everybody used to do. We used to go to send people to a sleep study at a sleep center. Now there's take-home sleep testing. The technology continues to improve over time that can give a good snapshot of sleep. Many insurance and payers want to start there, and then we'll move on to a sleep center. Circadian rhythm. Of course, people throw this off all the time. I often run into my teenager. Sunday through Friday, they have to be in bed at a decent time because they're waking up. It always drove me crazy. They have to wake up so early. Our little kids who wake in the morning at 5, 6 o'clock and normally don't give us a hard time. We want them to sleep in, right? The little ones, they're 7, 8, 9-year-olds, but they're up early. They should go to school earlier. But our teenagers are going to school super early. So our teenagers go ahead and they stay up on Fridays and Saturdays pretty much until 4 a.m., 5 a.m., and then they go to bed, sometimes 3 a.m. And then they sleep until 2 or 3 in the afternoon, if not later. And then Sunday they try to go to bed. And they can't. And this is typical of our police officers, our nurses, and anybody else, factory workers that do shift work, right? They all know that you're lucky if you only get 4 or 5 hours of good sleep, ever, unless you're off for a week, because that's just the nature of the game, because we have this natural sleep. There's a lot of research related to, and there's a new medicine that just came out, related to people that are blind to help them with this for the circadian rhythm. And the medicine is actually supposed to help with this for the impairment. People that are blind sometimes struggle with such on a regular basis. So just going through our different issues regarding sleep. These are just some factors to keep in mind overall, globally, related to parasomnolence, delayed sleep phases, age, stages of life, comorbid conditions again, environmental factors, controllable factors. When you're looking at the diagnosis, some key factors for parasomnolence. Often the biggest complaint is people do not feel like they've gotten an adequate amount of sleep, like they haven't slept at all. Risks for such: obviously the sleep cycle, medications, genetic, depression and anxiety. And you'll see a theme of depression and anxiety throughout sleep disorders. So many times when nothing else, when they start on the medical model of looking at everything, they go to primary care, they've ruled out everything else, then finally it comes to behavioral health. Nightmares. Don't forget, there are medications that will increase nightmares. There are medications, I always educate people that when I put them on a serotonin medicine, that it might increase their dreaming. It won't bring out nightmares, but if they have nightmares, it can make it worse. So be very careful with people that have a lot of trauma with SSRIs or certain meds, as well as, obviously, nightmares if they report. Rapid eye movement, sleep behavior disorder. Very hard to really diagnose overall. You'll normally see some like physiological, well, they'll be up and they'll be moving. They're your sleepwalkers, those clients. Restless leg. They can't remain still. Very classic antipsychotics will do this. We even have medicine to treat restless leg syndrome. Chronic pain also. Some medicines related to pain management. So differential diagnosis, we're always looking at the larger picture, medical mimics. So thyroid disorder, anxiety and stress, other sleep problems, substance use, medical problems, medications. This is often the sleep, the leg movement disorders or just movement disorders during sleep or some sort of obstructive sleep apnea. They actually need to have a sleep study, normally at a specific location. But with technology, I'm sure that will not need to happen in the future. Always want to look at medical disorders as you're looking at everything. Medications, medications, medications. It's very common. My blood pressure medicine changed from A to B. Whenever people complain about sleep disorders or even sexual disorders, when they're having some sexuality type of issues or sexual function issues, first thing I always go to is medicine. Have you changed any of your medicines? Any other provider? Blood pressure, diabetes, and herbal supplements. Alcohol consumption or drug consumption, that might be illegal drug consumption, and psychiatric illness. Evaluation of primary insomnia from a psychiatric history, depression, anxiety, substance uses, and eating disorders. You want to get a good medical history. You want to get a good sleep history. Keep a log. Evaluation of psychological stressors, anything that changed. Mood, anxiety, and depression instruments should be used.
Hello, my
Evaluate
name's Jim
for medical
Thompson, and I
problems and
work as a
medications
professor
over
in the
the
Department
counter
of Special
meds
Education at Illinois
and
State
herbal
University.
supplements. Teas that people make, the hot teas. I'm telling you, I've had that multiple times. Ask questions, partners or family members. Do they snore? Do they move a lot? Do they have irregular breathing? Substance abuse assessment, which we'll talk about more, but this is typical of what you want to know about. Then we also have the Epworth sleeplessness scale, and there's other scales out there that can be used. Assessment for depression and anxiety, lab work, sleep log, number of awakenesses, sleep medications. You want to educate them. Many times you can't wait, you need to start them on something, which makes it a little harder to get all the data. You want to look at their work, exercise schedule, their eating habits to try to pick up a variable. Big picture, you want to improve sleep quality and quantity. Improve insomnia related to daytime impairment. Improve insomnia, key factor there. Just improve insomnia related to key impairment. Improve sleep latency, time to fall asleep. People will worry about, will I be able to sleep? Will I be able to sleep? Reduce sleep awakening. If it's a matter of them using the bathroom, can we decrease the fluids after 6 o'clock? Patients will actually stop taking their diuretics because of it. Can they take their diuretic in the morning? Form positive and clear associations between bed and sleep. Watching TV, doing work in bed. Return to improved quality of sleep. Stimulation control. That's why hospitals change with lights and sounds at night. There's good, strong evidence to support this. Go to bed only when sleepy. Maintain a regular sleep. Avoid napping. Use bed only for sleeping and sex. If you cannot fall asleep in 20 minutes, remove yourself from the bed. Stimuli control. Relax techniques for about 20 minutes and then go back to bed. Relaxation training, low cognitive arousal type of programs. Progressive muscle relaxation, guided imagery, abdominal breathing, yoga, meditation, and muscle therapy. Cognitive behavioral therapy, increase positive belief about sleep. People that can't sleep, like I said, they'll lay there and they'll fight the meds even. I hope I can sleep. I hope I can sleep. Reduce unrealistic expectations about sleep. The 10 or 12 hours, going to bed at 7 or 8 o'clock. I didn't sleep well last night, so I got to get better night tonight. I cannot sleep without my medication. If I cannot sleep, then I should stay in bed and rest. Worry about anxiety over sleep. My life is ruined. Sleep hygiene. Keep a regular schedule. Get exercise every day. Room should be cool and dark. Room should be free of electronic equipment. No computer or iPad at least 1 hour before. No video games 1 hour before. Regular evening schedule and rituals for bed. No caffeine or alcohol or chocolate after 2 p.m. No excessive fluid. Use of white noise, such as room purifiers. Animals may need to sleep somewhere else. develop a routine, wake up regular times, avoid napping. And many times the elderly, or even some of my younger clients. Well, I watch TV 8 hours a day, or 6 hours a day, or 4 hours a day, whatever it is. But they're sitting in a nice, comfy chair in the living room or family room, or on a couch, and you talk with a spouse or another family. Oh yeah, they're dozing the whole time. They're taking these little naps throughout. Medications. A lot of medicines are benzodiazepine family or similar. Ambien. Just be very careful with sleep meds. Sleep meds are made for short-term use, if you read the label, even though you have people that stay on sleep meds for long periods of time. Check the narcotic registry and you can see if they've ever been on sleep meds. It's very classic that people will say they take their Xanax or Klonopin for sleep because it's anxiety. Melatonin is my go-to. Sometimes I tell people to take Benadryl. My ADHD kids, many times you give them a Clonidine or a 10X later at night, helps them sleep. So in summary, a comprehensive sleep assessment must be done. Look at co-occurring issues. Always ask about sleep as part of all visits. Explore their mood. As an advanced practice nurse, you can provide cognitive behavioral treatment. Learn more factors to help them relax and fall asleep. Follow the latest evidence-based guidelines for medications, first line and second line, as well as sleep hygiene and methodologies of falling asleep, as well as diagnostic criteria. And that concludes this section.